Next, we'll hear from Dr. Cynthia Ogden. Dr. Ogden is an epidemiologist at the National Center for Health Statistics, Centers for Disease Control and Prevention, overseeing the analysis group within the National Health and Nutrition Examination Survey. Please join me in welcoming Dr. Ogden.
Thanks so much. Let me see, I'm going to share my screen. Do I need to switch it? Which are you seeing, the regular, or is you seeing the notes?
It's not.
Okay, thanks. How's that? Great. So really, it is a pleasure for me to be here today to present a public health perspective on BMI. With only 10 minutes, it's really, this is not an exhaustive discussion, and I'm just going to provide a few examples of some points I want to make, and you'll see some overlap in some of the conversation we've heard so far today, which has been great. I have no conflicts to report. So there are strengths and limitations to using BMI, as you all know, in public health and surveillance and epidemiology in particular. BMI is simple and inexpensive, and at high levels, it's strongly correlated with body fat. And importantly, BMI is useful in looking at change over time on the population level. On the other hand, BMI is not a direct measure of body fat, as you all know, and it does not capture fat distribution, and it does not distinguish between fat and lean mass. And in addition, the association between BMI and adiposity, or BMI and health outcomes, varies, especially by ethnic group. So today I will show the usefulness of BMI in looking at trends and at distributions in the population, and illustrate a limitation of BMI in terms of a measure of body fat or adiposity, primarily related to differences between ethnic groups. First, a reminder of cut points and labels. I always feel the need to kind of center everybody. Everyone here is familiar with the definition of obesity. We've heard it this morning. In the US, the WHO definition or cut point of a BMI of 30 and severe obesity of 40. And I mention this to contrast cut points used in other countries. And for example, in China, obesity is defined as a BMI of 28. And this is because of differences in health risk at the same BMI, which I'll allude to later. In children and adolescents, BMI varies by age and sex, and a statistical definition based on a comparison to a reference population is used to define obesity, sex-specific BMI for age. So there are many different reference populations around the world. There are country-specific charts, the WHO growth standards from birth to 5, the WHO growth reference from 5 to 18, the IOTF cutoffs in the population that they're based on for 2 to 18, and then the CDC growth charts, which are used in this country. This table shows the different obesity cutoff used for three of these references. A z-score of 2 is used to define obesity based on the WHO growth charts, both of them. And based on the IOTF population, obesity is defined at a BMI of 30, the percentile at a BMI of 30 at age 18 years. And the CDC, based on the CDC growth charts, the cutoff is the 95th percentile. And unfortunately, I don't have time to discuss the differences in these reference populations, but these two impact the use of BMI in public health surveillance. So the examples I'm going to show today use data from the National Health and Nutrition Examination Survey. And NHANES is a nationally representative survey that includes physical measures, including weight and height. Based on the definitions used in the US, over 2 in 5 US adults, or 41.9%, have obesity, and 1 in 5, or 19.7% of youth 2 to 19 years have obesity. An important point to note related to obesity surveillance is that there's a difference in obesity prevalence based on self-reported weight and height compared to measured weight and height. And you can see on this slide the 41.9% I mentioned from NHANES measured data, and this compares at about the same point in time to 31.9% based on the behavioral risk factor surveillance system that contains self-reported data. And so in general, people overreport their height and underreport their weight. And there's some differences in groups, including differences between men and women. Now I'm going to turn to a strength of BMI in terms of obesity surveillance. So regardless of what cut point is used, as long as the same one is used over time, you can look at change or trends. This graph shows the trends in age-adjusted obesity and severe obesity among men by race ethnicity between 1999 and 2018. And from this, you can see there's a widening difference or disparity in prevalence, with the largest increase in prevalence seen among Mexican-American men. And you can see that in the orange line, where there was no difference between white, Black, and Mexican-American men in 1999-2000. And you see a different pattern in 2017-18. This graph shows the same thing as the previous one, except for among women. And these trends show increases in all race ethnic groups. Although if you look at severe obesity, the patterns seem to have changed some over time, with kind of a narrowing of the differences between Mexican American and Black women. Comparing trends over time in other subgroups can also be useful. This graph shows trends in severe obesity prevalence among men and in urban and rural areas. In 2001-04, there was no difference in prevalence. It was 2.8%. And it increased in both urban and rural areas, but it tripled in rural areas to 9.9%. So you see this widening disparity by urbanization. BMI is also useful for looking at the distribution across the whole population. So this graph shows the smooth distribution of BMI in all adults in 1999-2000 and 2017-18. So the area under the curve of the distribution shows the percentage of the population at each of the BMI levels along the x-axis. And so you can see that the whole distribution has shifted to the right and become slightly more skewed, so as the population has gotten heavier. Now I'm going to switch gears to illustrate some limitations in using BMI related to the association between BMI and adiposity or body fat. NHANES includes full body DEXA scans for measuring total body fat, so the next several slides are also based on NHANES data. This graph, based on a paper from Dr. Flegel, shows how differences in actual body fat can be mischaracterized by BMI. And here you can see US females 8 to 19 years of age in 1999-2004, there was a significantly higher prevalence of high BMI or obesity among Black females compared to white and Mexican American females. But when comparing prevalence of high adiposity based on DEXA scans, there were no significant differences. In more recent data from 2011-18, also on females, that show body fat and BMI, also that the differences are not consistent. So this graph now also includes Asian females. The difference in BMI on the right side shows that mean BMI among Black and Hispanic females was higher than among white and Asian females, and higher among white females than Asian females. On the other hand, if you look at the differences in percent body fat there on the left, mean percent body fat among Hispanic females was higher than among white, Black, and Asian females, but there were no differences between Black, white, and Asian females. So differences in BMI are not always the same as differences in body fat. This slide shows the distribution of age-adjusted mean percent body fat and BMI among males 8 to 19 years in 2011-18 by race ethnicity. Race ethnic differences in distributions of body fat and BMI are not always consistent. For example, on the left, the distribution of percent body fat among Black males in the orange line is to the left or lower than the other distributions. On the right side is the distribution of BMI, and you can see the distribution among Black males is shifted slightly to the right of the distributions of white and Asian males, reflecting a higher BMIs when you look at that graph. So this graph is a little bit more complicated. It reflects the change in percentage body fat and BMI between 1999-06 and 2011-18 in females 8 to 19 years. On the top row, you can see that among normal and underweight females, less than the 85th percentile, mean percent body fat increased from 29.5 to 30.1%, but there was no change in mean BMI in that group. Among females with obesity, however, mean percent body fat significantly decreased from 43 to 42.4%. Well, there was no significant change in mean BMI. So changes in percent body fat were not always consistent with observed changes in BMI. Before I conclude, I'd like to show one slide on BMI and diabetes. Disparities based on BMI may not translate to disparities in diabetes prevalence. So here on the left, you can see that based on BMI, the prevalence of obesity is much higher among white adults, 41.4%, compared to Asian adults, 16.1%. And this is a BMI of 30. But on the right side, you can see that the prevalence of diagnosed diabetes in the US population is not lower among Asian adults. They are in the blue box compared to white adults in the red box. So what are the key points about BMI and public health? Well, there are various BMI cut points and reference populations when we're talking about children. BMI is important, especially for monitoring trends. Self-reported weight and height underestimate BMI. And importantly, the relationship of BMI with body fat and diabetes varies by race ethnicity. Thank you.